Welcome to the Purr Podcast, your favorite feline-focused podcast, where we dive into all things feline, medicine, surgery, behavior, and of course, a sprinkle of veterinary gossip along the way.
I'm Dr. Jolle Kuppenstein, feline fanatic, surgery nerd, and self-proclaimed lover of all things awkwardly cat-related.
And I'm Dr. Susan Little, proud cat vet, podcast enthusiast, and your guide to the wonderfully weird world of feline medicine. Let's get started.
I am very excited to have our guest today for two reasons. One is that we've never had you on the podcast before.
Yay!
So we're always excited to talk to new people. And number two is that clearly you like infectious diseases. Oh, yes. And so that makes me very happy. Yeah. So Yola, you can drink your coffee or go do something, whatever you want right now. Just check back.
Excuse me, I'm on camera because, of the Patreon account. Not that a lot of people are following us there, but anyway, we are. And so I need to look very attentive.
Really?
Okay. And I might come up with some really good questions that nobody expects.
It's
about infectious
diseases. There's always a chance.
Right.
Always a chance. So I'm going to ask you to introduce yourself.
Absolutely. My name is Terza Brostoff. I am a DBM PhD board certified microbiologist.
That's nice. I don't think we've ever had one.
It's a small college.
You might be the first microbiologist.
I know.
Yeah, so I'm a DACVM at ACVIM.
Yeah.
One more time.
Diplomate of the American College of Veterinary Microbiology.
Like it.
Yeah.
Like it.
Yeah, with subspecialties in virology and immunology.
Ooh,
I think you're first.
Yeah.
That's lovely.
Excellent. So we'll deep dive into that.
What school did you graduate from?
All my training has been at Davis.
Okay, and you're an assistant prof?
Yes.
There at Davis now?
Yep, just started in September.
Oh, really?
Yeah.
Okay.
That's awesome.
And before that?
After I completed the dual degree program at Davis, I was in practice for a couple of years in the Bay Area in California, and then came back for a postdoc, and here I am.
What made you go back for a postdoc? What made you make that switch?
It was always in the long-term plan.
Okay.
But after graduating vet school, I really enjoyed clinics. I enjoyed clinical practice. I wanted to spend a couple of years learning what on-the-ground veterinary medicine really meant, learning how to communicate with clinicians, solidify my actual clinical skills. So I did that for a while. I was planning on staying out for 5 years, but then the pandemic hit, and I decided that was the perfect time to go back to academia.
Pandemic. Man, it changed a lot, didn't it?
It was rough.
Yeah. I really like it when I hear about people in the academic field and doing research who did have a stint as a clinician. I think that's really important, actually.
Yeah, the clinic I was at was just so incredibly supportive. I very much lucked out in the clinic I worked at for those few years. The doctors there are all fantastic. I'm still friends with a lot of them. And it was, I learned, you can't learn everything in vet school. It's just physically impossible.
Oh, true. Yeah. And you can't, you also just can't learn you can't learn to any good degree what frontline medicine is like, right?
100%. And what's practical and what's not.
Absolutely, absolutely.
So I hear PhD, I hear diplomats, probably double-boarded diplomats. So can you give a timeline in what you did, how you did this?
Yeah, I kind of went straight through. So I was in the dual degree program at Davis, the DBM PhD program there. I began in 2009, stepped out to do the PhD in 2011. Finished the PhD in 2015, and then wound up graduating with the vet school class of 2017.
Oh, wow. So they allow you to do that during your vet school?
Yeah,
cool.
It's a formal program at that school.
And how long is then the PhD part itself?
For me, it was 4 years.
Wow. That's fast.
Yeah, it is. It is. Some folks take a little bit longer.
Right.
Sure. I was very
My
well
PhD was a
mentored.
little longer. All right.
How long was yours, Yola?
I think I started in 94 and it was done in 99. So it's 5 years. So
yeah,
that's next to a full job.
That's-
Assistant professor job. So it's
that's true because he was Yola was a professor at Utrecht, right? And so so you actually would sort of put the DVM degree like on hold, go do PhD stuff.
Yeah.
Did you find that difficult, like the back and forth?
There's a rhyme behind the reason for
Okay.
why they do it that way. Because first and second year of vet school are mostly quite didactic.
Yeah.
The
Right.
goal is
Right.
to take that information, apply it to the PhD, and then to take kind of the research and assimilating information knowledge that you gain during your PhD and bring that back to the clinic for the
So
last
there's
2
a
years.
flow to it.
There is.
Okay.
I don't think there's any one perfect way to do. All of these programs are set up somewhat differently throughout the country where they're run. But if there was a perfect way to do it, everyone would be doing it the same. And I think this worked certainly well enough for me.
and if you compare your first 2 years with the last 2 years of your DVM,
Oh, I was a completely different human.
that's what I would think. Right. So
Yeah.
what are some changes?
Yeah, just my whole perspective on vet school and what it meant, and the way I was approaching learning at that point was very, very different than it had been the first 2 years. And part of that was probably content related, just because of what you're learning and how you're
You
going
learn
about.
you learn the ologies, and right? Yeah.
Yeah. And obviously much more didactic, and then the last 2 years are much more hands-on, much more practical. So, I definitely came back to it with a very different perspective.
I think it's really a cool idea. Normally, what happens is you finish vet school, then you do either a master's or you do a master's during your vet school, and then you do a PhD, which is very different. I think that the learnings that you have by doing a PhD, being scientific based, experimenting, and then coming back to vet school is really novel.
Yeah.
It's nice.
Yeah. And I mean, to be fair, most vet students probably forget all the information from the prior year's curriculum over the summer anyway, so it wasn't really that big of a deal.
It's in a textbook.
Yeah.
Yeah. So that's and it's interesting that that was your kind of goal from the beginning, right? You didn't get like partway through and go, hey, wait a minute. Yeah.
And then you went back to practice, or did you do your microbiology? Okay.
No, I went. So I graduated in 2017, and I was in private practice from 2017 to 2020. And I went back within a couple months of everything shutting down. So starting a postdoc in the middle of the pandemic was an interesting experience for sure. But I still preferred that over the way that things had changed, in the clinic.
And that was an essential job, so you could go into the lab.
Because we were studying a cat coronavirus, they made exemptions for everyone studying coronaviruses.
Right.
So,
and well, they should.
Yes.
Yeah.
So
we had our earlier guest today that we recorded was Jules Beatty. I'm sure you know who Jules is. Yeah. And I only hesitated because it got stuck in my head. Is it Beatty or Beatty? And once it's in my head, then I'm lost.
Don't tell me.
I mean, up until 9 o'clock this morning, I knew her name, right? And then something.
She messed it up.
Anyway.
After she said what the right one was, and then 5 minutes later she said, "Oh, Jules Beatty."
Once it got in there.
No.
Poor Jules. She's very gracious. Now, why did I mention Jules?
I don't know either. So we do a postdoc.
yes.
And how long was that?
I wound up doing that for just about 3 years.
And that's enough to then do your boards?
So there are a couple, for this particular college, there are a couple of ways to become board eligible. One of them is through a residency program. The other is to have a PhD in an equivalent field. So I went that route. So sitting boards for me was mostly self-study. So I sat boards in fall of 2021 and passed.
And I guess this is microbiology, and I can imagine the viruses are a part of it, but not the big. I mean, you need to learn quite a lot of other stuff too.
Yeah,
I can only think about bacteria. And,
so you have to subspecialize in at least one of the. So there's the parasitology segment of ACVM is completely separate. So it's a different general and a different specialty exam. The other three sections are virology, bacteriology, and mycology, so fungus, and virology. Sorry, did I say that already? Virology, bacteria, and immunology. Those are the three. So you have to sit, so general has all three of those, and then you have to sit one of the specialty exams I said.
Oh, I see.
Okay, so you don't have to do the specialty exam in all three.
Correct. No.
So it's general and then a subspecialty.
Bacteria are not my jam.
And then, does it say in your title that like vir at the back, or is it just you are a boarded microbiologist?
Does it say? I don't know. I don't remember what the certificate says. Yeah, probably says those two.
But are you allowed to say that to jump to bacteria, or will people say no? You did the virology exam and you can't do this.
Only if I sat it.
Okay.
Which I have no intention of.
No. I'm not saying that you have to. As a matter of fact, if you're happy with viruses, just stay there for sure.
So happy with viruses.
Right. So let's dive into the viruses a little bit. So what are you doing here at ACVM?
I'm giving 2 talks, both of which are tomorrow. I've been working with one of our internists at Davis, Crystal Reagan, on some of we have a lot of antiviral therapy trials for FIP going on. So I've helped with some of those. So one of my talks will be on that, comparing oral Remdesivir with oral GS 441524 in cats with non-effusive FIP. And, that does involve surgeons. We had a couple that were biopsy diagnosed.
Got to get a biopsy.
Yes, thank you.
For some of them.
Thank you for the shout out.
You're welcome.
So sweet. And what's the general conclusion of that?
They both work.
Both work as well?
Yes.
Very good.
Our study was relatively small. We had 20 total cats, 10 in each arm. We actually wound up losing or having relapse in more cats in the GS group than we did in the Remdesivir group. Yeah. I think when you only have 10 cats, it's kind of
true too.
It's small. So a difference of 2 cats is a big difference. So,
but so your findings fit in, though, I think, with the UK people and the Australians, right? It seems to be everybody's agreeing.
Absolutely. The big difference for this study was that both groups stayed on their same drug and were both being given oral drug the whole time.
Okay.
Right.
There was no parenteral Remdesivir. No, it was all oral on both fronts.
Right.
And both drugs are available as easy.
Oh, that's another question.
No.
See, I'm due ask some interesting questions. Yeah, thank you.
So I think everyone kind of has heard all the rumblings that Stokes is now making oral tablets of GS available. There is still no oral FDA-approved formulation of Remdesivir, but we can get a hold of the injectable form from the human side, but it's incredibly expensive.
So it's a bit of an access is a bit of an evolving story, right? Because before this, which is really kind of breaking news, owners were just ordering it online.
Yeah, but there was not an official.
It wasn't being sourced very much from this country.
Yeah, they were just ordering it online from Asia.
Right.
But what amazed me is that they were ordering it from sources where there was probably no quality control, like nothing, so you don't really know what you're getting. And yet, response rates still seemed to be positive enough.
Yeah.
Right? So despite the variety in what they were getting, that amazed me.
Samantha Evans recently published a paper looking at exactly what was in these drugs that were being sourced. And it ran the gamut. Most of them ran over what they claimed they had. So that
might be
fits with why the cats were, but a handful of, we're now seeing some uroliths. Made out of these compounds.
Last summer, the Minnesota Urolith Center.
That's a silica or not?
No, it was made of drug. It's drug.
It was the new one that they just popped up.
Last summer, it was their Urolith case of the month in one of the summer months last year.
Yeah, I remember.
Yeah,
that's really cool.
That's kind of crazy.
Jody Lulich, of course, would love this, but
that's kind of crazy.
So is that decreasing, or do they still see a lot?
Of what?
Virulus? I don't know. This does not seem to be a common problem. And in those two cats, if memory serves, and I apologize if I'm saying wrong things, I think both of them were on high dose drug, and both of them were on really protracted courses because they had some of the more refractory types of FIP. And so they were on really high doses for a very long time. And, it could have been even higher than they thought they were on.
So it must be uncommon because presumably thousands of cats by now, right?
Absolutely.
As a matter of fact, I'm going to send Jody a message and ask him, because he probably will know.
If there's been more?
Yeah.
That's interesting to know.
So.
Yeah.
Well, and, the other thing is hopefully now that we're going to have drug sourced from the United States with proper quality control and all that, we won't have these issues anymore.
So, excuse me, which pharmacy, remind me again, is making the tablets now?
It's going to be made by Stokes.
Stokes, right. And so do you know, were there any legalities they had to negotiate?
There were, and I don't know the details of them.
So I ask because in Canada in February, Health Canada, who the veterinary drugs is part of Health Canada. And so if you want to bring a drug in or administer a new drug, you have to have approval, right? And so in February, Health Canada approved the Bova pharmacy in the UK to supply these drugs to veterinarians in Canada. And that was a first of its kind because, as you know, there is no proper manufacturer. Do you know what I mean? They're compounded. And Health Canada has never approved a compounded drug from outside of the country ever before, obviously because of quality control issues. So it was a first of its kind. However, we have to go through a paperwork process.
Well, desperate times call for desperate measures.
Right.
And I think Bova worked with Stokes as well.
I wouldn't be surprised.
As they were developing this. But again, I don't want to say anything incorrect.
No, but I'm sure there was some maneuvering or some things that had to be, done.
So this must be very, very exciting for you because Dr. Susan is always talking about the two diseases that she wants to see disappear before she retires.
I didn't say disappear, but
and this was one of them because it's kind of a magical story.
It's horrible. It's an absolutely atrocious disease, and it's such a privilege to be in veterinary medicine right now when this is happening because we actually, one of the cats we treated was an RVT, a registered veterinary technician, and it was her own cat, and she's been in the field for a really long time, and she broke down crying at every single visit because she has seen so many cats die of FIP, and she was enrolled in our clinical trial, and her kitty did absolutely fantastic.
Right, and then for our audience, can you kind of explain what this drug does exactly?
What is GS? I just call it GS now because I can't keep track of the numbers. Right.
Yeah.
So it doesn't have a brand name because it's not a licensed drug, right? That's why we call it by its generic name, I guess.
Yeah, I have no idea. Right. So both Remdesivir and GS 441524, which is a mouthful, so GS it is.
You're good at that. Yeah.
Well, I've said it a lot of times. So Remdesivir is actually one of the parent compounds. It gets broken down into GS. And actually GS gets further broken down in the cat to the active compound. It's a nucleoside analog, so it looks like adenosine, but it prevents the viral RNA from being able to go any further than that once it gets incorporated. So by preventing the by preventing viral genome from being able to be replicated, it stops viral production.
But it doesn't stop normal.
Correct.
Because that's it. Because otherwise you would stop.
Right. It's preferentially incorporated by the viral enzymes.
Right.
Yeah.
Right. And do we know why?
You'd have to ask a pharmacologist for that question, or a chemist. I don't know. Neither.
Right. Yeah. No, I thought it was some specific viral,
Well, it's a nucleoside analog, so it works like.
No, I understand that, but I mean, I just wonder why the virus likes it so much. Well, normal cells that use also these replication methods don't.
I think it has to do with the viral enzyme, but I'm not. The enzyme prefers that.
Yeah.
But I'm not.
I see what you're asking.
Positive.
Yeah.
Not positive.
So the GS whatever story actually started a few years ago, right? Because there were other similar compounds, at least one other, I think, that appeared in the literature. And I know Niels Peterson, who I've known for a very long time, had done some other early work, correct?
Yeah, absolutely.
So do you know what happened to the other similar compound whose numbers I don't remember, but I know there was at least one other.
Yeah, I'm not entirely sure. I think this was one of the most effective, and so this is the one that they brought forward.
Right.
And interestingly, if memory serves again, I might be making this up, but I think towards the beginning of the pandemic, they actually looked at GS and found in humans at least Remdesivir to be better absorbed or something like that. But they compared the two, and they, Gilead was doing all of these trials, of course, and I think Remdesivir was superior to humans.
Right.
Or it was easier to formulate, something like that.
Yeah,
that was a reason.
Some advantage, In Canada, veterinarians don't have access to Remdesivir because the manufacturer won't sell it to us, right? So,
I mean, there are access issues here too. It's also really expensive.
Yeah.
Really expensive.
But GS is expensive too, you know, right? When you start
Remdesivir injectable.
Oh, I'm sure. Yeah. But I think that's one of the shocks. So we've treated several cats now at my feline practices, and one of the first hurdles you have to get over is that at least by the time Canadians can get it into a cat, it's tens of dollars per pill. Like, it's very expensive. But a surprising amount of owners want to do it. They want to do it.
And it's still going to be quite costly, but it is about on par, if not a little bit cheaper than what the average course of therapy would be sourcing it from other countries. And obviously it's going to be far safer. And with the added advantage that it's going to be oral.
Right.
That parenteral, the injectable is not fun.
And I think there were some issues with the injectable too, was there not?
In terms of dosing, it was the same. It was all across the board.
An injection site issue, something sticking in my head to do with the injectable, and I can't remember what it is.
The biggest issue with the injection is that solution winds up coming out around a pH of 1.5.
Oh, that's a problem.
So that's somewhere between lemon juice and battery acid.
That would hurt like...
So it's
that's
really
probably what I'm thinking about.
It's really difficult to give as soon as the cats start feeling bad. I mean, it's just horrible. They wind up with terrible skin lesions. And
that's what I'm thinking of. Yes.
No, it's by far and away preferable to give these kitties pills.
Right. So, so you mentioned that GS and Remdesivir seem to have similar efficacy. In terms of how you would prescribe them now, what kind of protocol are we settling into? Like, how long? And I know this is a big kettle of fish, but I'm asking you. Right?
I actually don't know. I'm not sure. I think there's a group that's going to be talking about it tomorrow afternoon. I think it can be ordered directly from Stokes. As of now, I know the dosing regimen is the same as it's always been. Still 12 weeks once a day, with follow-up ideally by their veterinarian as they're progressing through, to ensure that they're responding as expected, and then some follow-up afterwards to ensure that they don't relapse.
I think the UK group was talking about some particular forms, I think, like neurologic FIP might need either higher doses or longer treatment. So, I can see where not all, I mean, FIP is a different disease in its own way in every patient anyway, right? So I can see why.
The non-effusive form, and especially when the nervous system and the eye are involved, we tend to treat with higher doses. May or may not require the same length of therapy. I think probably that still needs to be worked out better. And those studies, I'm sure, will be coming down the pike. Well, especially as it becomes easier for owners to get the drug, and for for universities to get the drug.
Absolutely, just for researchers to know
I strongly suspect that, especially for the effusive cats, the cats with wet FIP, that we're going to be shortening that treatment course. I doubt that they truly need it for the full 12 weeks.
So that's interesting.
Yeah.
I guess it's partly we just never knew how long it would take, right?
Well, and I think because that was the original protocol that was established, and these owners are just so happy to have their cat back and not dead, that they're not a lot of them aren't willing to shorten it, especially now that they can give it orally and it's not fighting with the cat every single day to give those injections. I think the rather be safe than sorry, given that we know, with some exceptions, these drugs are generally very, very safe. That they're just, people are, it's going to be a hard sell, I think, to drop the course of treatment. Yeah.
Do you have a feel for relapse rate? And does it matter if you were a dry cat, a wet cat, a neuro cat? Do you have any feeling out of your own work? How is that settling out?
Yeah, so we definitely had more relapses with the dry cats than we did with the wet cats.
Why do you think that is?
I suspect it's the same reason that we use higher doses, is that it just doesn't penetrate the blood-brain barrier as well. It doesn't get across the blood-ocular barrier as well. And there's a little nidus of a little virus that as soon as we take these cats off therapy is able to, come back.
So that means that, before you ask the next question, that means also that the wet form, the virus is not able to penetrate
to hide as well. Right. So there's unfortunately a lot of overlap as well. So there are some cats with effusion. Well, and cats go back and forth between in either direction from wet to dry. But there are some cats with effusion that also have ocular lesions, that also have neurologic deficits. And so, I think it depends. In general, if it's an uncomplicated effusive case, those tend to not have as many issues.
Does it have to do with the time that the cat is infected at all, or is it?
It's really hard to say. So some of the cats we enroll, so the dry cats typically have a relatively short course of illness. From the days they start feeling bad to the days that they're close to death is, we have maybe a couple weeks depending on the cat. Some of these dry cats can go out for a really long time.
I was going to say that.
So one of our ocular cats, she was first presenting with signs, and she was a little bit older. I think she was around 3 or 4 when we enrolled her. She had lesions for months before they got a final workup and diagnosis. She actually is one of our cats that relapsed at the end of the trial. And from start to finish, she's been systemically well. She's had great energy, great appetite. She's a spicy jalapeno of a cat. She's one of the few that we said, for the next visit, you have to come back on gabapentin. She completed therapy in June of 2023. It is now June of 2024. She's still alive.
Yeah.
So
it seems to be the ocular ones that hang around forever.
Yeah.
And with that, we are at time.
Okay, I just have one last quick question.
Let's do that.
Yola, no, let me ask my question. I'll forget. Can I ask my question, Yola? I'll forget. Because I'll forget. So I just wanted to ask, on the face of it, the cats with dry FIP still have some immune response, right? Whereas the wet FIP guys, we tended to think of them as your immune system is not doing very well at all, right?
They're both responding from an immune standpoint.
But I think we sort of traditionally thought of the dry ones as having a little better control. Is that kind of idea?
I don't know if that really holds true. Now that we've seen so many cats, because again, we see cats go from one group to the other, and it's not always the same
that's very
direction.
true. Yes, it's not black and white. Right.
Liz Sparger at Davis published a study a number of years ago now, looking at actually the cellular response, not the antibody response, and again in a laboratory model, so not the real world, but they found that having a strong, robust cellular response to the virus
TH1 versus TH2 type.
And CD4 versus CD8. But the cats
right.
with the cytotoxic T cell response tended to be the ones that did better.
Yeah. So that's the better way to look at it than looking at it dry versus wet.
Yeah.
Yeah.
I think
Gotcha.
so. Yeah.
Okay, there. My question has been answered.
Thank you very much.
This is the Purr Podcast, where we talk cats, laugh a lot, and learn something new every episode. Together, we bring you the latest updates, surprising cases, expert interviews, and just a touch of chaos, because nothing with cats ever goes as planned.
So whether you're a seasoned veterinary pro, a new grad, or you're just here for the cat puns, you've come to the right place.